That was your website's not quite up to date. So she at one point left clinical work around about 2000 to focus much more on sociological aspects of health and illness. And her groundbreaking work, which I'm sure you're all aware of, on the sociology of diagnosis, focuses on how medical classification interacts with social and cultural interests. And she's written on medicalisation of overweight, on female sexuality, and on fetal death. Annemarie has focused on pharmaceutical and fitness industries as agents of medicalisation, and she's currently looking at the use of self-diagnosis in the management of pandemic influenza. As you also may know, because we've left some information on your seat, she's author of the recent commended and highly readable book, Putting a Name to It, Diagnosis in Contemporary Society, which was published in 2011. And she's author of numerous articles and editorials in the field of the sociology of diagnosis, including the joint editing of the recent special issue, well, it's 2011 special issue of Social Science and Medicine on the sociology of diagnosis. And anything else, I will let Annemarie tell you herself. Thank you very much.
First, we'll see if we can make the computer work. There we go. Here we are, and we'll start presenting. Thank you, Amanda, for your interesting illustrative starting point. The idea of a medical context for presenting sociological work is absolutely fabulous, and sociologists in this room will remember Glaser and Strauss's comments from Awareness of Dying when they said the thing that the sociologist does, or attempts to do, is to bring those things which the practitioner does every day in a pragmatic and banal, not banal, but in a pragmatic sort of way, bring another light to it and show some points that may not have otherwise been apparent. So on the one hand, that's what I hope to do, but I can see that Amanda is already well enlightened, as are undoubtedly many practitioners in this room, but possibly I'll bring a few other aspects of the diagnostic process and classification to your attention that the social scientists, on the other hand, will well be aware of. Anyway, we'll see what I say and whether this resonates. I'd like to thank Charlotta and Andrea for organizing the seminar and the other members of the group for their help in putting together the series. I'd like to particularly thank my friend Sarah Nettleton, with whom I've authored, well, we've really only authored one piece, but we authored it before we even knew one another. And we've now met twice, and this has been an excellent pretext for seeing her again. So I'd like to thank her not only for hosting me in New York, but also for inspiring me with her scholarship. And Robbie, to you as well. Your scholarship has been important in my thinking, and thank you for coming and for being part of this. Mainly, I'd like to thank all of you for being here, and thank you in advance for the insights that you will bring me. I don't pretend to know everything or even very much, but what I think I do through my own scholarship is facilitate the merging of ideas and the reweaving of ideas and thoughts that are already out there but just haven't come together in a focal point. And diagnosis has been a really useful focal point, I think, both for understanding sociological principles, but it's also a good heuristic for clinicians to understand how sociology works in wider society and in your everyday clinical practices. Before I start, though, I'd like to start as if I were in New Zealand, and some of you have been to New Zealand. Hands up, how many have been to New Zealand? All right, and you may have seen a traditional Maori greeting when you attended formal. I'm not going to do a full greeting, probably because there's not time, because you might be embarrassed by my singing. But I do that to my students. I do sing to my students and greet them when we start our year. However, the Maori tradition of using whakatoki, which are wise sayings or proverbs, the one that I'd like to use today is Ahakua he iti he punamu, which means even though it's very small, it's still a treasure. And that signifies the starting point from which this discussion is taking place. So it's a little bud which hopefully will turn into a flower, or punamu, which is the greenstone treasure that the Maori make reference to. So I'll start now. But before I start, I wanted to know how many of you are in clinical practice in this room. Could I see hands? Okay, possibly a quarter of the people. How many of you are sociologists or cultural theorists or? Okay. All right. Well, my talk today attempts to bridge the two. So from theory to practice. Now, considering something from a sociological perspective brings different lights on the mundane things we do every day. That's what I started by saying earlier. But it also can provide us with insights into understanding what works, what doesn't work, and the potential avenues for change. So to start with, I'd like to refresh your memory about what constitutes a sociological. And of course, since the majority of people in this room are sociologists or cultural scholars, I perhaps don't need to do that. But for clinicians, we tend to think of our job, and I speak as a clinician, as being a simple interaction between the layperson and the doctor or the nurse or whoever might be attending to their care. But in fact, there are very strong structural, cultural, and political factors outside the individual interaction between two people, which we need to be aware of. And it's an awareness of that sociological perspective that I hope to elicit today, and I'm going to do it via diagnosis. The diagnosis is a social action and a social thing par excellence, but I'm going to introduce this to you progressively and start with some broader principles, of course. So looking at something from a sociological perspective, we want to look at what kinds of things, regulations, conditions, norms, and values are at play in the diagnostic encounter. Diagnosis is, as I previously alluded, a particularly useful tool for understanding sociology, as we'll see a bit further along in this presentation. But before we get to that, and we'll just see how this Prezi works, here's the sociological, I'm going to use a different example to start talking about sociological content. So this is an image which is not about diagnosis. Here we have a picture of an arrest. At the surface level, it's a picture of good guys and bad guys. For mainstream New Zealanders or Brits or Americans, we would see this perhaps as an example of police officers arresting a hooligan. But from a sociological perspective, we can see quite a bit more. We can see a young person acquiescing to the power of a social authority in whom is vested the power to arrest. He's not striking out because of social regulations which require him to abide by a set of agreed upon laws and regulations and sanctions. Now, possibly he's being arrested for urinating in public, and I use this carefully as my chosen example. The reason I'm doing that is it's been regulated as improper as a result of social norms about what constitutes decent behavior. However, if you were a distance runner out on a track in a hidden woods urinating, it would not thought to be indecent. And I guess the point that I'm trying to make is that this picture shows far more than just an arrest. We can see a confirmation of public structures, institutions, and norms. Now, you'll see my picture floating about in the background, and that's on purpose. I've put it here because I want to underscore the fact that most of us, even the most healthy, and I should actually underline the fact that I'm really comfortable in this building because I did both my undergraduate and my PhD studies in the School of Physical Education. Even as healthy and as active as I might be, or as any of you or other people might be, the way we consider health and illness in contemporary Western society is very frequently, even for us, shaped in diagnostic terms. So the sociological shapes what this mad mountain biker shapes whether I think I'm well or not, and it shapes how I conceive of my injuries and illness, and I'm going to use one of my recent injuries as an example in a few moments. So the same holds true in medical setting. In the act of diagnosing, structures and institutions and norms are all united in a similar way as we saw in this arrest earlier on, yet in a way which is probably less apparent to us as we practice within that environment than it is when we look at something which is outside. So as I explore diagnosis, I'm going to be asking questions about its social role, how it sits in institutions, how it's operationalized, what structures support it, and importantly, what consequences it has on those diagnosed and on those doing the diagnoses. So starting at the beginning, we should perhaps reflect upon how diagnosis defines medicine, both in the eyes of its practitioners and those who elicit medical support. So diagnosis does define the profession. It differentiates the lay from the professional. It differentiates me from those primary care physicians in this room? I asked if you were clinicians, but how many of you are doctors? How many are something else? Yeah. So me, something else, and I can't diagnose, or I'm not legally entitled to diagnose. So diagnosis is one of those pivotal points of authority and points of definition. So when individuals may give a label to that which afflicts them, you know, I have a cold, I have a flu, if they need to find out what's making them sick when they don't know, they will generally go to the doctor. The doctor is the one who has the authority to take the definitional stance, and we'll talk about some of the consequences of that definition a little bit later on. But what happens when you don't feel well is you take a pre-definitional stance, often formed by public and community messages and beliefs, that the sense of illness is the result of disease, as opposed to, say, the result of moral failing or poor training. You go see your coach if you're not running fast enough. You go see your minister or your rabbi if you have some spiritual thing. You go to your doctor if you have something that you think is medical. With this belief, the individual consults a doctor, and I guess I should also probably point out that the layperson may come with a definitional stance, presenting what they have to the clinician and asking for confirmation. This, of course, can be a source of tension when the two are not on the same page, but it can also be a source of information for the clinician who's receiving the definition, and of course, a place of laborious work, perhaps, in these cases. You possibly have read the work of Michael Balint, who talks about the negotiation that takes place when the physician attempts to present the diagnosis. You have to package it, and I think, Amanda, that's probably what you're talking about as well, putting it in a way that your patient is able to understand, accept, and settle with. Without that settling, you have a very difficult time moving forward. But with the diagnosis comes a bunch of other things. You get the prognosis, the treatment, the identity in some cases. I'm a gout sufferer, or I have cancer. Or, sorry, I don't have cancer. I hope I have cancer. But the idea of being a cancer sufferer or a cancer survivor is putting yourself in a different identification group. It has a very important transformative impact on the person receiving the diagnosis. But we'll start by exploring some of the fundamental structures which frame this interaction and which can lead to the consequences of resource prognosis, treatment, identity, and many other things. We'll start with classification. It's a social act. In order to be able to draw on a diagnosis, you have to be able to find it in some agreed upon taxonomy. Sorry, these fish are examples of things that might need to be classified. You can, for example, diagnose idiopathic linguistic dystonia. Do you like that? I invented it. Because it isn't agreed upon and it hasn't entered into the taxonomy. You're going to go to a classification system. You will, I'm sure, all be aware of the fact that psychiatric diseases and those diseases for which there isn't a blood test often move between social institutions. States which deviate from the norm may fluctuate between social consideration as crime or moral depravity and illness. Now, I think I may have messed up these slides, but we'll see. No, I haven't. Here are some examples. I have on the one hand Zach Guildford on the left. Who knows Zach Guildford? No one knows Zach Guildford? No, rugby player for New Zealand. Yeah, great, yeah. So Zach's got a little problem with alcohol. And that problem has gotten into all kinds of trouble. In fact, he was on sort of probation and he did it again. His coach has said he's very ill. And he's 3 times? Yeah, 3 times. He hit someone, he ended up naked in the Cook Islands, he's done some bad stuff. And going from being a hooligan to being alcoholic is a very distinct difference in the way that his problems have been addressed by the media, probably by himself, and certainly by Rugby New Zealand. On the other hand, we have Cardinal Napier, and Cardinal Napier, you may have heard, it's Wilfred Fox Napier, and he has argued that pedophilia is a disease, not a crime. The consequences of making statements like this, I know these shocked people when I put it on my blog, that we might consider pedophilia a disease, but there is certainly a trend for seeing things that are on the edge of our moral tolerance as being, in a first instance, a moral problem, and in a second instance, a medical problem. And at this point, we treat pedophilia as a crime, which means that the locus of responsibility is in the individual rather than in the disease. So thinking of the consequences of how we classify is very important. And we need to go back, because I didn't do my slides properly, but in our classification systems, anyone who has followed, of course, the history of the DSM, and we're seeing a new DSM revision come out today, will be well aware of how particular disorders have negotiated shell shock as compared to PTSD, homosexuality, female, don't remember, maybe one of you will remember the... Oh, well, hypoactive sexual desire disorder. I forgot I wrote an article about that, didn't I? But there are numerous classifications. Psychiatric disorders are low-hanging fruit, as Phil Brown once said, for the sociologist of diagnosis because of the complex problems or definitional problems that they raise. But physical disorders, too, are influenced by social factors. And I can give you the example of influenza as one starting point. During the 2009 H1N1 pandemic, the ICD Update and Reference Committee decided that a new category for coding swine flu need not be created. Given the limited use that was made of the code put in place for avian flu in 2005 with no deaths recorded, the recommendation was made that clinical coders should code swine flu against avian flu. So pigs were flying because conveniently there was this code, empty, lovely, ready to use, so they just stuck it in there. But classifications do more than just identify diseases. They're also professional documents, particularly the DSM, which determine the state of the field. And I think the response of the British Psychological Society's clinical psychology branch is an interesting example of that. And perhaps I'm speaking out of place because I've only read the Guardian review of that. But the clinical psychologists have stated that they will be moving away from diagnostic category, whereas the psychiatrists are holding firm. Oh, that's not the right button. Let's go to Thomas Arnold's. Thomas Arnold, headmaster of what school? Rugby, of course. Rugby school. Wrote that we are not to suppose there are only a certain number of divisions in any subject, and that unless we follow these, we shall divide it wrongly and unsuccessfully. On the contrary, every subject is, as it were, all joints. It will divide wherever we choose to strike it, and therefore, according to our particular object at different times, we shall see fit to divide it very differently. And while he was not talking about classification of diseases, I think we can see that in reference to any of the diseases to which I've just made reference, and to a number of others as well. But classification, okay, so I guess Arnold is confirming this, and I want to say it in a different way. Classification is a social endeavor. It is not fixed. It is governed instead by consensus. Thank you, Robbie, for writing that. By debate, by authority, and classifications can and do shift. I would like to read you this fabulous example from the Ancient Chinese Encyclopedia, which is the Celestial Emporium of Benevolent Knowledge. In this tome, they explain how animals are divided. So listen carefully. A, those that belong to the emperor. B, embalmed ones. C, those that are trained. D, suckling pigs. E, those that tremble as if they were mad. F, those drawn with a very fine camel's hairbrush. G, those that have just broken the flower vase. And those that at a distance resemble flies. How curious is that? Now, as Emily Martin once wrote, and it's just such a useful comment, we don't usually have, history gives us distance to be able to see the social content of the things that we do. So we're usually not very good at examining the social content of the stuff in front of us. And I think this Chinese example is a very good one. But let's try to see if we can see some of the social content in our contemporary society. And I start with these weight charts, which you possibly can't see. This is Kuczmarski and Flegel if anyone is working in weight, probably knows Flegel's work. She's an epidemiologist. And this is simply, from 1942 to 1995, height for weight charts, what would have been normal. And I love standing up and telling you that I'm 1.71 m shrinking, and seeing what category I would be in over the course of these things. And then I always like rugby examples. Sorry if this is boring you. But the cute little rugby halfbacks who are the same height as me, because I'm about the height of a rugby halfback, particularly with my shoes on. And I wouldn't want to have that weight on the field. But of course, how desirable the weight would be would depend on the circumstances, the context, and obviously the year that the classifications were devised. And you will perhaps know that in 1995, and I can just slide this up, or maybe it was 97, all of a sudden a zillion people became overweight because they shifted the boundary. Now, Flegel will also argue, and has demonstrated in some very large-scale epidemiological studies, that actually overweight people are healthier than normal weight people in terms of morbidity and mortality. Obese 1 are probably about as healthy as normal weight, and the serious consequences of weight only occur at the very obese levels. Let's see what my next slide is. I think it's these lovely eyeballs, and the reason I put them here is just because they were so lovely. I photographed these a couple of days ago at the Musée pour l'Histoire de Médecine in Paris. And I thought they might come in handy, but I really just wanted to share the image with you. The museum, it's a lovely little museum at the medical school on the Rue de l'École de Médecine. Costs €3.50 to get in, and was really quite lovely. So if you get a chance, take a look, particularly if you have any interest in surgery. This, on the other hand, is an image which stayed with me from about 1982. My husband picked up a book in the airport called French for Cats, and you're supposed to put light humor in presentations, but I actually do think it's illustrative. What we've got here is the boundary set up by people, and here we have the boundaries set up by cats. The tomcat across the street, moi, le chat tigré de la maison d'à côté. But it is an important illustration of the fact that boundaries aren't real. We make them. And who we are and how we make them will determine what they actually are. But I think my next slide is then going to show you what the consequence of that, as Ian Hacking has said. The idea of nature has served as a way to disguise ideology to appear to be perfectly neutral. No study of classification can escape the obligation to examine the roots of this idea. No study of the word natural can fail to touch on that other great ideological word, real. And to put that into perhaps plainer English, and perhaps to vary the position slightly, I'm not sure that it is an issue of ideology. What I am sure of is that once we draw the lines, once we package something as a diagnosis, we are far less likely to debate any longer those outliers, those things that didn't quite work, the points of view that were divergent. So a classification, a diagnosis, sets up what is real and what is not real, and shuts down conversations. So what happens once the diagnosis exists as a structure is that it privileges some voices and silences others. Now, I'm going to show you this next diagram, which I hope you can read. This is my little model. Sociologists like making models. And this is a model which I call the social understanding of diagnosis. And what we have here is, on the one hand, the classifications of diagnosis and how they're socially framed. Thank you again, Robbie. Social framing, I choose to use that word rather than social construction, because many times people are of the impression that social construction means that things aren't real. At no point am I trying to argue that we do not have real, tangible symptoms and disorders, but how they end up being framed and put together, on the other hand, is a social activity, which includes things that we will be going over, maybe not quite box by box, but pretty much. And on the other side, we have the social consequences of the diagnosis, which feed in to how things are framed. In the middle, of course, we have the doctor-patient or lay professional interaction, the diagnostic moment or diagnostic process, which I'm not going to spend as much time on today, and that has already given us a good start. Now, if we start here, technology was on my screen. and my notes aren't quite together, but here we are. Technology does a lot of jobs in diagnosis. It adds to the clinical picture, providing insight which may be completely useful to arriving upon a diagnosis, but it may just as well trump the clinical picture, providing the putatively objective finding that cannot be debated, or is it concealing the clinical picture? There's a great deal of tension there. One reason, however, that we place so much faith in diagnostic technologies is because we think of them providing an objective glimpse of the body and disease, free of the complexity of human emotion. But they add, we think that humans occupy a murky world of emotions and interests, and that machines operate only within the objective world of facts. But diagnostic technologies seem to provide us with some internal glimpse of how things really are. However, I'm sure that everyone here who works in a diagnostic setting or who has received a diagnosis, because I think that's one of the interesting things about working in this field, is that most of us too are shaped by think about and get diagnosed. You can all, sorry, wrong button. You can all think of a diagnostic test which failed to confirm what you thought you were looking at in the patient, or took you in a direction that you didn't think was best for your patient, or revealed something that you wish you didn't know you had, and that might have been completely irrelevant. Sorry, I didn't mean to go there. I've messed up my slides again. We'll come back. So I've been talking a lot about how marvelous Prezi is, and I do think it is, but I'm not using it very well. So forgive me. We have the problems of overdiagnosis, and I've taken this straight from the BMJ page, and I'm sure that many of you are aware of some of the issues that that arise from technology and the over-observation of disorders. But now we also, I just want to come back to technology and look at the medical record also as a form of technology. While electronic medical records do allow you a great deal of information and benefits to the clinicians and to the patients, they also force you to make choices about diagnosis that you might not have had to make before. Some of you may remember drawing pictures on your notes and putting little arrows, little dots, and showing how the pain radiated from here to there. And now you have to work with drop-down boxes and force labels. And external agencies may mandate how you choose labels or push you to one label over another. And now we get to come back to me on my mountain bike. My recent mountain bike is a good heuristic. Mountain bike accident is a good heuristic. Any mountain bikers in the room? Okay, I impaled myself on my handlebar. It was a bit sore. And the Accident Compensation Corporation, who takes care of accidents in New Zealand, so we have separate little systems, uses read codes. Do you use read codes here? I think you developed them in the UK. Yeah. So I got picked up by the EMTs. I first heroically walked out of the bush, clutching my breast, and the EMTs picked me up. And the EMTs, and I'm also one of those, so I have to do this kind of notation, and it was kind of cool watching them do it for me between gasps of breath. They had to vacillate between the SE2 ... and the SE21. Was this a contusion trunk or a contusion chest wall? No, says the doctor when he comes into the emergency room, it's an S120 ... fracture rib. This is in the Ranfurly Hospital, of course without x-ray, little rural hospital far from anywhere. So because of medical authority, power to diagnose, we erase EMT diagnoses and we put medical diagnosis of S12 from this clinical diagnosis. But I go see my own GP a few days later just to make sure that this rural country doctor, who's fabulous, had done things properly and find out if there was anything else I need to do. And my GP adds SE20 ... to the form contusion breast. The reason for that, of course, is if I have funny calcifications on a mammogram 2, 3, 4 years from now because of the hematoma created from the accident, it needs to be on ACC for administrative purposes, because then I have the shortcut to services. ACC is better coverage than standard medical coverage. Okay? you all know this kind of thing. And I've since learned, I was with Gordy Schiff. Does anyone know Gordon Schiff? Yes, was visiting him in Boston last week, and he informed me that in the United States, you actually have coding specialists who come behind in the general practices to make sure that the way you've diagnosed your patients and how you've coded them will get the optimum coverage from the private insurance companies. Yeah. So they employ people to do this, and it saves them money. Okay, back to our model. We are looking at risk factors and surveillance as another component of the social understanding of diagnosis, and that's also out of order, forgive me. Let's go to risk profiles right here. In our risk profiles, and I think Robbie's going to be speaking about this much more later, we've got the issue of disease potential. It's a fascinating topic, and it is a means of social control. It's amplified by the ever-expanding technical access to new screening tools. And what I've got on this picture, of course, is the promotion of screening, so know your risk, the idea that the more you know about yourself, the healthier you will be. And of course, we have with that the demand for more tests. I'm not quite sure how it would work with the NHS, but certainly you can send away for lots of tests in the US. You're likely to think that the more you know about what's inside of you, the better and more healthy you'll be. It also raises important questions, and you can see that cute little baby who's a Down syndrome baby. We have universal Down syndrome screening offer in New Zealand, at least. Are we contributing to some sort of a eugenic experiment? Or are we contributing to some improved health outcome? That's a subject for debate elsewhere, but it's obviously a very important subject. By exploring risk profiles, this eVista drug is for increasing bone density, so it's a potential point of exploitation. And that final picture is an Alzheimer cell thing. I don't know. Do I want to know my risk for Alzheimer? It seems to be, again, one of the overarching goals of media promotion of mental health and protection moving forward is we should know, or should we? I don't think I want to know until you've got something to help me. Hopefully we'll go where I want to go next, but we might not. A little bit embarrassing not quite to get it right this time, but I did, yes, good. This is disease discovery, and there are clearly forces on how diagnoses come to be recognized. We've spoken about technology, professional recognition, and I think one of the important things here is that, and I think, sorry, I'm babbling, can I regroup? Let me come back. In order for diseases to be recognized as something that might eventually end up entering a classificatory system, we need to have awareness and some sort of interest in promoting them. So we could talk about female hypoactive sexual desire disorder, which was a disease highly promoted by pharmaceutical industry interests. But here we have some other examples, and I think, Robbie, you'll recognize some of them, and what I'm going to say here may be incorrect, but it comes from my interpretation of your work, which is around Lyme disease. And there is no debate about the fact that there is a spiral sheet which causes the disease. But Lyme disease could never have been discovered, to my reading, if it had there not been a cluster, and we can see some examples of clustering on that slide. Had it not clustered in a place where we had educated upper-class mothers willing to advocate and step out and speak for their children, had they not been able to enlist the professional support of clinicians and eventually the CDC, that's all very social, even though the disease was real. And the disease could have gone unrecognized as a nonspecific febrile rash-producing illness for much longer, or perhaps forever, had it not been found in that area and in that context, in that social context. And this picture, the picture of the little red dots on the lady's body, is a fibromyalgia website. And so we're looking at a contested diagnosis where we have, again, a lay-driven process, highly contested. And I can't quite comment on how discovered and how cemented the fibromyalgia and other at this point, medically unexplained symptoms are in the systems, but it's a very important component to recognize in the whole issue of the social framing of diagnosis. Now we're going to look quickly at the social consequences. On the other hand, on the other side of my little model, nope, see, here we go, get out of those pictures, because I didn't do it right. And it's all being taped. How fabulous is that? I don't care. I think we maybe can edit that out, but if we can't, that's all right. One of the important roles of diagnosis is that it can legitimize. It allows us to stay in bed. We all have read Parsons' sick roll. We possibly can take leave. We can be looked after rather than looking after. But in exchange, we're expected to be compliant subjects, following medical instructions and making every attempt to get better. The diagnosis allocates the resource, so I'm not going to be able to get that prescription if I don't have the diagnosis. Obviously, there's some over-the-counter things I can help myself to, and there's some alternative things that I can help myself. But if I want to stay in mainstream Western biomedicine, I'm going to have a diagnosis. However, it also enables exploitation. And here we have some pharmaceutical advertising. The first one is around influenza, and it's an advertisement obviously for Tamiflu, and the other one is around female hypoactive sexual desire disorder. You don't lust enough, go get diagnosed. It also enables stigmatization, and it's a very important thing to consider. You may be surprised at what your patients will find stigmatizing. HIV, we all know, but actually recently, put this on my blog, but there was a diagnostic test for syphilis somewhere here in the UK that incorrectly reported 75 cases of syphilis that actually weren't syphilis. I don't know if you guys give the treatment for syphilis, but I've given it before. It's this nasty 20 mils of penicillin G in a huge syringe. It hurts a lot, it's nasty. And in fact, the comment of the lab was these people got a dose of penicillin that they maybe didn't need to have. There won't be any consequences. Well, yeah, but did they go home and tell their lover that they had syphilis? Did they tell anyone else? Did they contact people they'd had sex with? There are a lot of consequences of diagnosis that are more important than that lab director thought about, certainly. We're also going to look at stereotypes, and you'll see this young, vigorous man walking into your practice and complain about gastric burning, and you might not think to explore the idea of heart attack, but maybe you should. I don't know if it's happened to you before, but it certainly is reported. The aesthetic of health can be a confounding factor, and we do have stereotypes. This young woman might be experiencing obstructive sleep apnea, but she's not a fat middle-aged man, so you might not access that in your diagnostic hypotheses. Nor might you think that this overweight woman would be actually leading aerobics classes in addition to exercising more than you in your medium-sized frame might do. And I love this one. I got this from JAMA, I think. How good is this? Americans can identify this perhaps with this more clearly. Rah-rah, musical, African Americans, Christians, all go to church, sing on Sunday. Wait a second. Yeah. This is for a type 2 diabetes treatment. So targeting advertising on the basis of ethnic stereotypes. What I, and I'm actually going a little bit quickly here because we're running short on time, just perfect. We have also issues around authority and how authority can be threatened. That's Dr. Google on the top right-hand corner, and that's technology on the bottom. There are many ways in which the traditional roles of diagnostician and layperson are overlapping. One might see these as opportunities or as threats. I'm actually currently doing research on self-diagnosis of influenza. It's really curious that medicine lets lay people decide whether they have this particular disease. Stay at home if you have the flu. That's the public health message, and yet people use flu as a metaphor for most non-specific systemic febrile illnesses. Now, what I really want us to think about as we think about diagnosis from a sociological perspective is it is a crowded room. That picture was also from the Museum of Medicine last week. It's so fabulous. This is Charcot's Leçon Clinique. In that room, we have values and norms. We have industry influences. We have social health movements and patient advocacy groups. We have information circulating from many different sources. We have authorities, and we have many different authorities. So the person who comes, say, with their sore shoulder, may be interested in acupuncture, may believe in acupuncture, perhaps more than they believe in anti-inflammatories, and understanding where their authorities fit with respect to Western biomedicine is extremely important in ending up having a successful consultation for both parties. Belief systems, professional hierarchies, funding and finance, who's getting paid, who needs to be paid, where's the money coming from, who stands to benefit, technologies, and many other things. It's more than just a social encounter between one clinician and one layperson. But there's much at stake, and I don't have a very good picture for that, but those are stakes. There's role definition, and think of the fibromyalgia sufferer who has not been allowed the sick role, perhaps. There's legitimization, the ability to access care or to be allowed to stay home. And I was going to say, in my influenza research, what was really interesting talking to people was they wanted to see the doctor so that they could be allowed to slow down. They couldn't allow that on their own. Certainty. I wanted to know if it was the flu or something worse. But I think, Amanda, you talked about certainty already in your clinical encounter, and it's an extremely important thing to ascertain how badly your patient is clinging to certainty and whether or not you've been able to assuage their needs for it. Allocation, some things you can't get if you don't get a diagnosis. But on the other hand, we have uncertainty, and we need to know how to negotiate that. We have role transformation, and that may be around identity shifts, but it also may be around the way the layperson becomes more authoritative and brings in a story, a definitional story, rather than the pre-definitional story that they might have brought in 10 years ago, or probably 20. The problem of uncertainty, oh, I wrote that twice. We'll edit that slide too, shall we? And here we have, just to tie up, my mnemonic. So I've written a mnemonic, and actually a lot of this is around the fact that I've just finished editing a textbook on social aspects of diagnosis, and we know that doctors like mnemonics. Med students do. Well, I don't know if doctors do. Med students do. Do you like mnemonics? May I ask the question? Do you not like mnemonics? How many of you do you not like mnemonics?
I can never remember what they mean.
Okay, you can't remember what they mean. Well, imagine this.
Because I'm so old.
I'm very old too. And actually, I hope I can remember what I meant to say by this mnemonic, but I'm imagining, the bookmark in the lab coat pocket, helping us to remember. And so what this mnemonic is attempting to do is give some guidance to the clinician who has already got a biophysical hypothesis or pathophysiological hypothesis, but still needs to consider the social overlay as they think about what the diagnosis is, as they provide that diagnosis to the patient, or as they move forward in treatment. The C is certainty. How important is certainty in this particular encounter? What can we do to reduce the need for certainty? And is there anything else that we need in order to be certain if certainty is required? Label. What does the label do, and what is it going to give access to? How important is it to label this with a medical diagnosis? Can it be labeled in some other way in order for access to be granted? A, alternate. And alternate is around the alternate authorities and belief systems that the patient brings to the encounter, and it's about evaluating how medicine fits in. And I've got some really poignant examples from gout and Polynesian patients in New Zealand, very Christian group, very, very Christian group. Rheumatologists don't want to go there, absolutely don't want to go there. But the rheumatologist sent us to talk to the Polynesian men who have an incredible incidence of gout to find out what was going on. Why weren't they being compliant? And the problem was this huge disjuncture. Part of it was ignoring these men's reality, which is, I am a minister, I'm a good person, I cannot therefore have gout. I'm a Christian, I cannot have gout. I am a good person. Because, if we look at the next slide, or the next word, the social context meant that gout was perceived in that particular social group is a great black mark. Only alcoholics have gout. And in fact, they were interpreting their knee pain as coming, or their foot pain, or wherever they had it in various sites, is coming from old injuries from rugby, from differences in temperature, having moved from Samoa or Tokelau to New Zealand where it got cold. So without evaluating the alternate belief systems, there was no purchase, none. So social context, understanding what that is, and stigma. And in this case, the case of gout, it was very stigmatizing. Gout was a bad label, and it was a label that the gentleman didn't accept because of the social context which defined gout in a particular way. Information. Where does the information that your patient brings to you come from? What does it tell you about the patient? So that information isn't threatening, it's actually informative. Funding. Who stands to benefit from this financially? Who's paying? NHS may be a little bit different, but not that different, because you too are subject to pharmaceutical pressures, to all sorts of things, incentivization, many other things. And then very importantly, the why of classify is you. Go back and classify yourself. Ask those same questions about you. How important is certainty to you? What does this label mean to you? What do you think that that label means about your patient? What are the alternate belief systems to which you subscribe? Not people are lazy. Anyone think that? You don't have to put up your hand. I bet you do. Many people do. Or, I don't know, muscly people. There are all sorts of belief systems to which you adhere. You might be Christians with a strong belief. You may be neoliberals. You may be all sorts of things that influence how you perceive the patient in your room. Stigma. Does the fact that this guy had gout make you think that he is responsible for his gout? Are you stigmatizing him and thinking of him as a lazy person? What are your information sources and how robust are they and what are their limitations? And the founding question is self-evident. And there we go. I think that's over time. Forgive me. But thank you very much.